This is QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live, January 27, 28. Next month in Dallas. Be there. Today's case, Eosinophilia in rheumatoid arthritis. I don't know that we ever talked about that, and I saw that in clinic the other day, and I thought, well, we should probably bring that up. It came up in the context of a 46-year-old woman who has had rheumatoid arthritis for about 14 years. She's currently taking etanercept weekly and just Tylenol, 3 or 4 a day. She's fairly well controlled. She says she's doing good. Morning stiffness less 10 minutes. She sleeps well. Her pain level is a 2. She has occasional pain in her wrists and elbow and rarely the right ankle. I go through the exam and I find, I think, a few, maybe 2 tender joints, no swollen joints, no nodules, no extra-articular manifestations, no sign of disease activity. And her labs are pretty normal. Normal chem profile, a SED rate that's normal at 13, a normal complete blood count, white count 9,000, hemoglobin 13, platelet counts 315. She's got an eosinophil count of 765. And normal is up to 500. So what's going on there? Am I going to make any changes in her therapy? No, her RA is stable. It's been stable for a while. And she's doing well. She's not taking any other drugs per se, but then on further questioning, I find out, wait, she's taking an inhaler. She has a history of asthma. She has a history of eczema. So that's the probable cause here. But the story really is that RA patients can get eosinophilia too. Let's look at her past medical histories and see if there's a clue there. She's got NASH, eczema, obesity, prior latent TB that was treated by me, depression, and occasional GERD. So other than my giving her, a systemic eosinophilic disease, this is going to be due to RA or her atopic disease and asthma, right? I don't think she has eosinophilic esophagitis. That's a new one, right? But let's go with differential diagnosis of eosinophilia in RA. It does happen. First, if you look at the literature on this, a lot of that comes from countries where there's a lot of parasites. And you've always got to exclude that. So if your patient comes from, as outside the United States and when they were born, where they were raised, and where they've lived most of their life, parasites are a reality. In one study from a foreign land that I think appeared in ARD, 160 patients with eosinophilia, 30 patients, or 19%, 20% had allergic diseases, a few with bronchiectasis and lung disease, but 20+% had intestinal parasites. And when those were cleared and treated, then the problem went away. Second would be atopic disease. Both eczema and asthma more likely to give you eosinophilia at times, and that needs to be factored in. But there's a lot of very old literature. I remember when I was doing my fellowship in the 80s, you would see patients with, fairly high eosinophil counts, above 10%, and they would stay high. And in the early days of when they were writing about this in the 70s and 80s, it was thought that this was a sign of more aggressive rheumatoid arthritis. When you looked at case series on this, 5 patients, 40 patients, 100 patients, peripheral eosinophilia, which could be 20% to 80%, they had more severe articular disease. They were more likely to have extra-articular manifestations, vasculitis, pleuritis, and subcutaneous nodules. They had elevated immunoglobulin levels across the board, leading some to suggest this was heightened immunologic activity in very severe patients, and that somehow resulted in more eosinophils being produced. Again, whether or not this is associated with extra-articular manifestations has been a matter of debate. Again, literature in the 70s and 80s said, yeah, maybe more vasculitis, pleural pericardial disease, nodules, etc. But more recent data, where clearly we're being more aggressive, patients are not getting as severe. I mean, it shows up in clinic. When I was in my fellowship in 1984, the clinic was riddled with crutches, wheelchairs, and gurneys. I never see a gurney anymore. I seldom see a wheelchair. I rarely see a crutch. See some canes, however. RA's changed over time. Some more recent reports between 2015 and 2020, you're looking at series that basically show no association with extra-articular manifestations. But it still does happen. It's usually related to atopic disease. It may be related to more severe disease nonetheless. There are those studies that show that these patients may have higher HAQ scores over time, may have other evidence, more likely to be on DMARD. So again, it can go along with aggressive disease, but it behooves you to look for background underlying disease that could be the cause of eosinophilia in patients with rheumatoid arthritis. That's it for QD Clinics today. Remember, RheumNow.live, we answer your questions. Questions you say, that's right. Shorter lectures, a lot of Q&A. You know, we have these 2-hour sessions called pods on RA, PSA, SPA, vasculitis, lupus. And in that 120 minutes, we have 3 lectures and a panel, and a total of 45 minutes devoted to audience, Q&A, and interaction. And it's even more if you count in the polling questions that the speakers are going to do during their 25, 30-minute lectures. So a lot of interaction. Your answers are important to you, and why shouldn't your question be taken and answered? That's what we pay attention to at RheumNow.live. Tune in for more QD Clinics.